Hi, my name is Dr. Manbinder Sidhu, and I will be giving a presentation titled Acute Hospitals Managing General Practice Services in the UK. Why, how, and what are the consequences for primary care delivery. I will be sharing findings from a qualitative rapid evaluation study completed by the Birmingham, Rand, and Cambridge Brace NIHR Centre for Rapid Evaluations. My co-authors are Jack Pollard and John Sussex. Vertical integration can be described as an acute hospital taking responsibility for GP contracts and hence running GP practices. That is, integration between organisations operating at different stages along the patient pathway. All examples of vertical integration between acute hospitals and GP practices in the NHS also entail an element of horizontal integration. No hospital has merged with a single GP practice, but rather always with a number of practices, and hence those practices are effectively integrated horizontally with one another as well as vertically with the hospital. So, why vertically integrate? Vertical integration brings the opportunity to redesign services. It can address problems with governance, funding, and differing objectives and drivers, can reduce transaction costs, and enhance the ability to involve both primary care and secondary care clinicians in the design of effective and efficient clinical pathways. For patients, it can improve continuity in care and foster more seamless transitions between teams and services. Therefore, organisational vertical integration between hospitals and GP practices may help overcome coordination challenges. We should note we are setting out on the focus of an integration aspect, the blue boxes in the diagram. But as we go into the field, we realise that the dominant rationale was to enable GP practices in difficulties to keep going. More on that green box later. There are some notable examples of vertical integration both in the UK and internationally. Southwark and Lambeth Integrated Care attempted to integrate care across primary, acute, community, mental health and social care. Northumbria Primary Care were 6 practices in Northumbria being run by the local foundation trust. The Al-Zero model is a single healthcare provider receiving a fixed annual sum per inhabitant to supply free universal access to a range of primary, acute and specialist hospital services in Valencia, Spain. And Kaiser Permanente, an integrated healthcare delivery system providing care for more than 12 million members in the US. Following a Brace horizon scanning approach for innovations suitable for rapid evaluation and a project design workshop held in March 2019, the team decided to complete a rapid evaluation which had 2 distinct aims. Aim 1 was to understand the early impacts of vertical integration, its objectives, how it was being implemented, whether and how vertical integration can underpin and drive the redesigning of care pathways, whether and how services offered in primary care settings change as a result, and the impact on the general practice and hospital workforces. Aim 2 was to develop a theory of change for vertical integration, thus identifying what outcomes this model of vertical integration is expected to achieve in the short, medium and long terms and under what circumstances. We designed a rapid evaluation with 3 distinct work packages. Work package 1 was a rapid review of the literature, telephone scoping interviews and a stakeholder workshop. An overview of the evidence already reported on vertical integration of secondary and primary care services and to inform the development of propositions to be tested throughout comparative case studies. Work package 2 were the comparative case studies for 3 vertical integration sites, interviews with those involved in the conceptual design, implementation and analysis of this model of vertical integration at their respective sites, analysis of key documentation, both internal and publicly shared and that relevant to patient experience, non-participant observation of strategic meetings, and interpretation of existing metrics and cost information being collected by and any quantitative analyses undertaken at the case study sites. Work package 3 was the development of theories of change, including a workshop meeting of the full research team plus other senior qualitative researchers from the University of Birmingham and Rand Europe to develop a theory of change for each case study site as well as an overall theory of change for this model of vertical integration. For the purpose of this presentation, we will present findings from Work Package 2. We selected 3 case study sites in England and Wales, Site A, B and C. Site A, an acute hospital trust, which is one of the largest acute and community providers of health services in a socio-economically disadvantaged urban area of England. Integration with primary care practices was initiated in 2016, when 3 general practices approached the Acute Trust. As of March 2020, the Acute Trust has integrated 10 practices, treating approximately 1/3 of their local primary care population. Site B. In 2015, prior to the official formation of the Acute Trust General Practice vertical integration model, the local health economy became a vanguard for a PACS new model of integrated primary and secondary care. The vertical integration takes the form of the Acute Trust 100% owning a limited company, which by late 2019 was running GP services for a group of 13 practices, together holding 9 GP contracts following mergers between some practices and covering a total registered population of approximately 80,000. Site C. A local health board in Wales providing a full range of primary community mental health and acute hospital services for a population of around 700,000 people in a rural and coastal area. The local health board has directly managing GP practices since 2015 as a result of GP resignations. There was no strategic intention for the local health board to directly manage GP practices. As of March 2020, the local health board has received resignations from 22 GMS contract holding practices, which were consequently being directly managed by the health board. Some of these 22 practices have been merged or dispersed with other managed practices. Regional teams have been developed, East, Central and West, to oversee GP practices. Managed practices continue to work with regional primary care clusters comprised of both managed and non-managed practices. The findings for Site A show the central rationale for integration between the Acute Trust and primary care practices was to better manage demand in the local health economy through improving patient access to primary care services, increased quality of care, and increasing opportunities for innovation. The Acute Trust was feeling the impact of a poorly resourced general practices upon secondary care, with many patients accessing emergency care at the Trust because GPs are experiencing increasing workloads with fewer full-time clinical staff. Integration required stakeholders from primary and secondary care to establish a strategy built on shared values on how best to deliver care to patients and the ability to adapt pathways so that more patients could be treated in the community rather than in the acute hospital settings. The impacts which have resulted from vertical integration are the sharing of real-time data from secondary care to primary care practitioners to manage high-risk patients. These are most likely to require emergency secondary care. Other findings show the upskilling of the primary care workforce, the development of a primary care specific division within the Acute Trust to support the restructuring of back office functions. However, there have been some notable challenges, such as the high cost of locums. The predominant rationale for vertical integration at Site B between the acute hospital and several GP practices in its catchment area was to enable those practices to continue in the face of recruitment and financial difficulties and where the traditional partnership model was no longer sustainable as a result. Implementing vertical integration, which involves the limited company running GP services with the company 100% owned by the Acute Hospital Trust, required a substantial upfront investment of time and effort by the senior management at the Trust and leading GPs. The provision of centralised back office functions, drawing on those of the Acute Trust, and the creation of a central management team for the vertical integration company supported GP practices and has been successful in contributing to the viability of primary care financially. However, the company is still operating at a loss. Primary care practices have more multidisciplinary teams than previously, including access to some specialist services via specially trained practice staff and limited outreach from the acute hospital. The rationale for Site C was to address the immediate crisis of a high number of general practices closing and consequently integrating them within the health board because there were no other viable alternatives. The reasons for closure were an aging profile of existing GPs, being unable to attract new GPs within a traditional partner model, and increasing GP workload. The local health board originally planned to return GP practices to GMS contract holding providers. However, due to the ever-increasing number of general practices returning their contracts to the health board, the strategy for managed practices shifted. Thus, while general practices remained integrated with the local health board, the rationale was to improve patient care through the regional application of multidisciplinary team working. Integrated practices made it easier to make changes to clinical pathways for patients, especially between primary and community care, more so than between primary and hospital care because of geographical constraints faced by patients attending distant acute hospitals. Attracting GPs to a rural coastal area remained difficult, especially in remote locations, while locums remained expensive and a scarce resource. Therefore, the local health board created attractive portfolio-based career opportunities for salaried GPs. Nearly all staff would eventually receive improved contractual terms on Agenda for Change, which brought perceived greater employment security. There are a number of strengths and limitations. The study team was able to establish strong relationships with gatekeepers over a relatively short period of time, and all 3 sites remain interested in a further evaluation on the effectiveness of vertical integration. However, the team struggled to complete a high number of non-participant observations. There was a stop-start approach to collecting data throughout the evaluation, and the onset of COVID-19 prevented the team from sharing findings with case study sites in a timely fashion. In conclusion, the main rationale for vertical integration across our case study sites was to sustain primary care. Secondary objectives are demand management and better care integration. This was achieved by employing GPs and practice staff, taking on financial risk and running of the GP business, improved recruitment of GPs and locums, and an upskilled primary care workforce. Further, the sharing of back office functions, improved communication between GPs and hospital clinicians all had effect. However, there is a need to bridge the cultural divide and manage tensions between secondary and primary care, which takes effort and time. Thank you for listening to our presentation. We would love to hear from you, either via email or providing comments below the video. If you would like more information about BRACE, please click on the link provided on the slide.